So, picture this. A patient walks into your clinic. They've got a high fever, body aches, maybe a nasty headache. You're in an endemic region, so you know the clock is ticking. This isn't just some run-of-the-mill fever. This is a high-stakes diagnostic challenge.
So, what's the call? Is it dengue, typhoid, or is it malaria? Getting this wrong isn't just an inconvenience, it can be fatal. In this explainer, we are going to decode these big three illnesses. We're going to bust some really dangerous myths and give you clear, evidence-based protocols that you can use on your very next shift. All right, let's get into it.
First up, dengue, the infamous breakbone fever. Now, everyone gets hung up on the platelet count, right? But the real killer here, the thing you have to watch out for, isn't just the bleeding. It's something called endothelial leak, where the blood vessels basically become porous, and that can lead to shock. Now check this out, because diagnosing dengue is all about timing. In those first 5 days, when the virus is actively circulating in the blood, you have to test for the NS1 antigen. After day 5, the virus is pretty much gone, but the antibodies are starting to rise, and that's your window to test for IgM. And see that IgG trap? You got to be careful with that one. If you see a high IgG early on, it's a huge red flag for a secondary infection, which, as you know, often means a much worse prognosis. Okay, this next point is absolutely non-negotiable. Management rule number 1, no NSAIDs. I mean it. No ibuprofen, no diclofenac, none of it. They're toxic to platelets, and they seriously increase the risk of bleeding. For fever control, the only safe game in town is paracetamol. Let's bust the biggest myth out there, what I call platelet panic. Everybody obsesses over the platelet count, but just staring at that number alone is a huge mistake. The real predictor of severe dengue is a rising hematocrit. Why? Well, think about it. As plasma leaks out of those blood vessels, the blood gets thicker, more concentrated. A 20% rise in hematocrit, that's your critical warning sign that your patient is heading straight for shock. So let's put you in the hot seat with a classic clinical dilemma. It's day 3 of the fever. Your NS1 and IgM tests both come back negative. But you look at the labs and you see the platelets are dropping and the hematocrit is starting to creep up. What do? The answer is a huge, resounding yes. According to WHO criteria, a strong clinical picture plus those key lab trends is more than enough for a diagnosis of probable dengue. You do not wait for a positive test. The takeaway here is crucial. You start aggressive hydration and you start it immediately. That's what saves lives. All right, let's switch gears and talk about our second fever, typhoid. And for this one, we have to talk about the single biggest diagnostic error that I still see being made every single day. And yeah, I'm talking about the Widal test. Look, in areas where typhoid is common, tons of people just have baseline antibodies floating around. So doing a single test, it's completely meaningless. It tells you nothing. The guidelines are crystal clear. Unless you have 2 samples taken weeks apart that show a 4-fold rise, a single Widal test is not diagnostic. It's a lie, it's a trap. So if you can't trust the Widal, what do? You play detective with a simple, complete blood count in that first week. First, you look for leukopenia, a low white blood cell count. Then, relative bradycardia, the fever's raging but the pulse is weirdly slow. And third, the golden clue, absolute eosinophilia. That's right, 0%. If your patient has a fever and their blood report shows 0 eosinophils, typhoid needs to shoot right to the top of your list. It's an incredibly specific classic finding you just can't ignore. And because of that, you have to treat empirically. You don't wait. The clinical picture plus that CBC triad, that's your signal to start antibiotics right away. Waiting 48 or 72 hours for a blood culture to come back is a dangerous game that risks a life-threatening intestinal perforation. All right, on to our third major fever, malaria. Specifically, Plasmodium vivax. Now, Vivax is sneaky. It has what I call a bunker strategy. It leaves these dormant parasites called hypnozoids just sleeping in the liver, totally ready to wake up and cause a relapse months down the line. That means your treatment has to be a 2-step process. So here's how it works. Step 1 is you clear the acute infection that's in the blood right now. For that, we use chloroquine. The easiest way to remember the adult dose is the 4-4-2 rule. 4 tablets on day 1, 4 on day 2, and 2 on day 3. But that only solves half the problem. Step 2 is you have to clear the liver with a 14-day course of Primaquine. That's how you prevent the relapse. But stop. right there. Before you even think about writing that prescription for Primaquine, there is one critical safety check that you absolutely positively must perform. Missing this is a huge deal. You have to screen for G6PD deficiency. It's a genetic condition, and in patients who have it, Primaquine acts like a bomb. It triggers this massive destruction of their red blood cells, causing a severe, sometimes fatal, hemolytic anemia. So the rule is simple: always check the G6PD status before you even think about starting Primaquine. Okay, it is time for another Mythbuster. And honestly, this is a common and really dangerous misconception I see in malaria management all the time. So let's say your patient's fever from the acute malaria is gone. Their G6PD test is normal, but you notice their platelets are still a little bit low, maybe around 80,000. Do you delay starting the Primaquine? The answer is a clear and simple false. Primaquine can cause hemolysis in G6PD deficient patients, yes, but it does not cause low platelets. It has nothing to do with thrombocytopenia. There is zero reason to delay treatment. In fact, delaying it just puts the patient at risk for a totally avoidable relapse down the road. So what happens when you've tested for the big three and everything comes back negative, but your patient is still sick? Well, it's time to go hunting for the imposters. There are two critical diseases you've got to consider: scrub typhus and leptospirosis. For scrub typhus, you need to look carefully all over the skin for an eschar. It's a black, kind of cigarette burn-like scab. For lepto, just be aware that it can perfectly mimic severe dengue shock with multi-organ failure. The good news? Both are on the rise. Yeah, but they also both respond beautifully to a simple antibiotic, doxycycline. Okay, so we've covered a ton of ground. Let's pull all of this together into a single practical protocol that you can take away and literally use on your next shift. And here it is, your cheat sheet. For dengue, avoid the platelet panic and focus on the hematocrit rise. Hydration is everything. For typhoid, you're going to ignore that single Widal test and trust the CBC Triad, treating based on your clinical suspicion. And for Vivax Malaria, you're never going to delay Primaquine for low platelets, but you will always check for G6PD deficiency first. So there you have it. You're now armed with the evidence-based protocol to confidently manage these really complex fevers. So the final question is for you: which one of these common clinical myths are you going to be the one to bust on your next ward round?